Hi everybody, and welcome to week 9. As you can see from the slide, the sort of main area that we're going to be covering in this week is what we often call the golden hour, although we're going to sort of really talk more about the golden hours, and that's an interesting sort of shift as well from talking for a long time about the importance of that first hour following the birth of the baby, and now with more and more research that is available, particularly about the human microbiome, which is another topic we're going to cover today. There's a growing understanding of how important it is, in fact, that the baby is in skin-to-skin contact with mum for really as long as possible, hence the plural of the golden hours. Also, we're going to actually start off really by just doing a quick look at breech birth, actually, and you'll find some extra resources that you can read in your own time about breech as well. But I just thought it would be important just to kind of give a little bit of information about breech birth as well before we move on. So so predominantly the topics that we're looking at are sort of immediately following birth, and also how that looks different depending on whether the baby is born vaginally or via cesarean section, as well as a little bit about obviously how you as the doula play a very important role in helping to support these early postnatal hours, and then just also a little bit as we finish off kind of what that looks like from birth to essentially to discharge home. What sort of time frame are we looking at? Again, how does that vary depending on whether the birth was uncomplicated and just a sort of straightforward vaginal birth, or were there more complications? Was it an emergency cesarean, for example? So those are the sort of things that we're going to explore today. So you've probably all heard of breech babies, and you can see from the illustration here that in fact there are a number of different breech positions that baby can be in. Breech basically means a position whereby the baby's main presenting part is either usually the buttocks or in some cases a foot as well, and hence the different types of names that we refer to: a complete breech, a footling breech, a frank breech, for example. On the next slide we'll look at how common breech babies are, and then also what the options are, the birth options for somebody whose baby is in a breech position at term, meaning essentially at the end of their pregnancy. So how common is breech? Well, you can see here on the slide that at term, about 3 to 4% of babies are in a breech position at the end of pregnancy. It's much more common before that. So you can see at 28 weeks, about a quarter of babies are breech. But by the time you reach sort of around 32 weeks, that early third trimester, most babies are starting to settle into a head down position. It doesn't mean they're not going to still move around, and they certainly can move around even in a head down position from sort of an anterior to a posterior position. They still have plenty of room to move around and still may actually do full flips. But as the space decreases in the uterus, then babies do typically find their way into a head down position, certainly by around sort of 34-35 weeks of pregnancy. What's interesting, or maybe not particularly surprising, is that the vast majority of babies that are breech at term are now born by planned cesarean. So not emergency, not unplanned, but basically if they can determine the baby's breech via palpation, so feeling, but always that is backed up by an ultrasound as well to confirm baby's position, then babies are usually booked in for a planned cesarean around 39 weeks, sometimes as late as 40 weeks. But I suppose the reason for booking in a slightly earlier C-section around that 39-week mark is to avoid the possibility, or at least largely reduce the likelihood of mum going into spontaneous labor and then them having to deal with a breech vaginal birth, which, to be honest, many birth settings now really have inadequate experience and expertise to be able to support vaginal breech birth. And we'll talk a little bit more about that in the next slide. And you can see that, that the number of breech vaginal births has dropped very significantly. So of that sort of the 3 to 4% of babies, we are talking small numbers, about a quarter of them would be delivered vaginally back in the early 90s, but by the early 2000s that number really plummeted to 3.7%, and I would say that number is certainly even lower today. It's a very rare occurrence for a vaginal breech birth, and that's usually down to 2 reasons. One, a very determined mum, and an equally supportive care provider. Otherwise, it would potentially be a very precipitous, quick labor, where baby was born breech essentially, without a whole lot of warning, and certainly not enough time to have a C-section. So we'll look on the next slide as to why these numbers have dropped so dramatically in the last few years. So before I start, I just wanted to get you all to look at this extraordinary photo of a breech baby and his or her delightfully scrumptious little squishy lips as baby emerges, with the head coming last. So anyway, some extraordinary photos. If you Google breech vaginal birth, there's some great videos out there and some wonderful photos as well. So why is breech vaginal birth so rare today? So it's important, again, to just look a little bit historically, and I say historically, I'm really only talking about 30 years or so ago, so not a huge amount of time. Breech was considered really just to be a variation of normal. Certainly, okay, there weren't huge numbers of breech babies, but the ones that were breech at term, there was the confidence, there was the skill set, and there was the experience amongst doctors and midwives to confidently manage a breech vaginal birth. And it was, it certainly is an obstetric and a midwifery skill. It's not something that you would want somebody who didn't have that experience and confidence to support a birth in that way if they didn't have the experience. So the reason that these numbers have so dramatically dropped in these last 3 decades or so really points to the release of a study which was published in a very prestigious UK medical journal called The Lancet, which some of you might have heard of, and it was called the Term Breech Trial, and it was published in 2000. So there you go. I mean, that was almost 22 years ago, thereabouts. And you can look it up. It's certainly freely accessible. If you just type in, again, Term Breech Trial, probably you'll have a better outcome if you search on Google Scholar rather than just regular Google. But essentially what the researchers found is that they concluded that babies who were breech at term had poorer outcomes if they were born vaginally versus those who were born via cesarean section, and their poor health outcomes were, included things like risk of baby developing having a birth injury, going on to develop something more serious, and like cerebral palsy, for example. And like a lot of quite dramatic studies and things that come out like that, it had a very considerable influence and effect on the international medical community almost overnight, and effectively kind of was the death knell for vaginal breech birth. What's really interesting, and again, not so surprising in the research world, is that since the release of that that study. It's been looked at and re-looked at, and many doctors have actually been quite vocal in saying that they feel that the Turnbreach trial was actually a really poor study. It was very flawed in its design methods, and in fact, in many circumstances, vaginal breech birth is certainly safe. Where are we at with vaginal breech birth and availability today, particularly here in Melbourne? Very limited. In the public health system, extremely difficult to find a hospital and provider who will support it. From memory, I believe Monash Clayton is probably one of the only hospitals that will support it. The Royal Women's in the city used to have a breech clinic, actually, until really quite recently, until only about maybe 6 or 7 years ago. But that has since closed down. And in the private sort of obstetric sector, there are a very small handful of obstetricians, private obstetricians, who will support vaginal breech birth, and I could probably count them on one hand. But again, if you have a client who's going through the public system and certainly doesn't have access to private obstetrics, the options are very limited. So I think it's one of those things where you really need to just sort of talk with your client and find out, first of all, what their thoughts and feelings are around baby's position, and if they are showing signs of wanting to explore a vaginal birth, then there's some really good resources you can send them. One of the materials actually you've got in Better Impact is a small ebook actually that I put together about breech birth. You're welcome to forward that to people. But I would encourage your clients first and foremost to speak with their care provider and find out if there are any options available to them, if in fact they are really keen to explore the option of a vaginal breech birth. So that is essentially where we're at today. And the next couple of slides we're going to look at options that may help to turn a breech baby, especially given how small the options are available as far as vaginal birth. Many women are instead looking to find ways that they can actually help to get their baby to turn into a head down position, and thereby hopefully avoid a cesarean section because of baby's position. So we'll look at a few of those options on the next few slides. So the main medical option that's available for somebody who is looking to try and turn a breech baby is a procedure called ECV, which stands for external cephalic version. So version basically means it's the turning. Cephalic is the head down, and the external obviously is from the outside. So you can see in the photo there, you've got a doctor who is doing an ECV, and one of the videos actually that you can watch, which is going to be uploaded for you, is actually a Melbourne obstetrician called Joe Segroy. And he had a video, quick little video showing him doing an ECV on a patient of his. So you can sort of have a quick look and see what it looks like. So it's performed usually around 37 weeks, and by which point it's not to say that it's impossible for a baby to turn into a head down position all by themselves, but it's less likely because there's not a huge amount of space left. So before the doctor would start, and I should say that just because somebody's an obstetrician, it actually doesn't make them an expert in ECV. It is a very specific procedure that requires quite specific training actually. So again, if somebody is looking to have an ECV, depending on where again they're birthing, there may or may not be people who are really skilled in this particular procedure. So before it starts, the doctor would do a quick ultrasound just to confirm that baby's head is still, in that breech position, and to confirm where baby's bottom is and back and all the different body parts, and also to look at the amniotic fluid around the baby as well. And that's important that there is an adequate amount of fluid around the baby. They're also looking obviously for the position of the placenta. It's another thing that they need to have a full understanding of where everything is. Usually the mum will also be given a medication, and it basically is designed to relax the uterus and prevent the uterus from to contract, and not, ideally not to go into labor. So that's done also prior to the ECV. And then the baby is obviously monitored continuously throughout this procedure, and they're having a listen to baby to make sure baby is tolerating the ECV well. It's very quick. It rarely takes more than about 5 minutes, and sometimes it's even faster than that, just a minute or two. Depending on the experience and the skill of the practitioner, the success rate can be as high as probably around sort of 65-70%, which is actually quite high, sometimes higher. But there is always the possibility that baby will flip back again. It can be done again, but there is a sort of a belief that if a baby is sort of continuing to flip back into that breech position, there's probably a really good reason for it, and there's this sort of understanding that we don't always understand everything, and that the baby's trying to tell us something, and we should probably listen to baby in those circumstances. And so there's often not a whole lot of encouragement to keep doing things like this if it hasn't worked generally the first time. So that's ECV. And again, if you have a client who has a baby in a breech position close to term, around that sort of mid 30 week mark, as in sort of 34, 35 weeks, so or thereabouts, and she is keen to avoid a C-section, then she should definitely start having some conversations with her care provider about the options available to her, be that vaginal breech birth or be that ECV. And on the next couple of slides, we're going to look at some of the sort of more natural methods of potentially helping a baby to turn as well. So in addition to ECV, or instead of ECV, but there's no reason why these things cannot be done together, there are some more natural methods which potentially could also help to turn and flip a breech baby. Again, these sort of methods, there's some more information in that breech ebook, which you can have a read of. And there is varying degrees of evidence to support how beneficial these are. But for all of them, there is some good evidence. So the most simple is just maternal positioning. So it involves mum doing a series of exercises usually on a daily basis, which are sort of reverse gravity type positions. You can see in that bottom picture there, mum is doing a breech tilt. So she's effectively going against gravity, and if baby needs a bit more space in the upper chest and under the rib cage, baby can sort of move out, and she's making room for baby. And there are variations of that breech tilt as well. Couple of websites that are worth looking at. One would be Optimal Maternal Positioning. The other one would be Spinning Babies, and they would both have some really good information about exercises for maternal positioning with the breech baby. There's also a chiropractic technique called the Webster technique. Not all chiropractors are trained in the Webster technique. So again, it's about finding a provider who has that specific training and experience. It's often will be chiropractors who work very much with pregnancy and postpartum rather than just general chiropractic clinics. The Webster technique is basically a technique designed to provide better alignment, pelvic alignment, and space, and pelvic space as well. It's about making more space for baby to potentially move and into a head down position. There's also a couple of traditional Chinese medicine options. There's something called moxibustion, which involves burning of Chinese herbs near the baby toe, the baby toe being an important point on the body, which can also be activated by acupressure and acupuncture. So there is moxibustion, which somebody would need to go see a TCM practitioner and be shown how to do it, but it's actually something that can be done at home once they've learned how to do it. And then there's acupuncture as well, which obviously needs to be done by an experienced TCM practitioner and acupuncturist. And again, I would strongly advise that the acupuncturist themselves is very experienced in pregnancy and postpartum care, and that's a sort of area of speciality. And then finally, rebozo. So, we talked actually at our last in-person session about the use of traditional rebozo or using a scarf. But again, there are a number of positions like the belly sifting, I don't know if you remember, where mum's hands and knees and partner can lift the baby and just gently rock from side to side. There's also the shaking the apples, which is sort of, again, just designed to just sort of loosen muscles around the lower back and the sacrum, and may form part of an overall sort of sequence of positions and activities that mum might do on a daily basis that may help to, again, make more space and give baby an opportunity to move. So a lot of women will find themselves doing kind of all of the above plus ECV and giving themselves every possible opportunity for baby to turn. But certainly if by the end of 37 weeks, give or take a day or so, if that baby is very, very suddenly in a breech position, then really there really are just sort of the two options available at that end point, and that would be a vaginal breech birth, which has been discussed thoroughly between the woman and her care provider, or a planned cesarean section. Which brings us actually to our next topic, which is to look at cesarean section. Okay, so we're going to talk a little bit about cesarean birth, and there are some also additional resources that you can read up on as well. There's some information in the student workbook, and there's also a couple of pages in the Preparing for Birth booklet. So you'll see them in the sort of extra things to read and assignments for this week. And I was going to say also, a video where it's called A Woman-Centered Cesarean, which is a great little video. It's not at all gory, but actually is a really great way for you to sort of think about how a cesarean birth can actually become more family-centered and more woman-centered. And these are suggestions that you might want to pass on to your future clients should a cesarean birth become necessary. So this slide here doesn't really go into the process of a cesarean birth. Again, you'll find more of that in the particularly the Preparing for Birth booklet. It's more just to sort of point out some of the risks associated with cesarean birth, and that's because unfortunately cesareans have become so commonplace and so widely accepted as just an alternative, you know, a completely normal and acceptable alternative to a vaginal birth. And our C-section rate, you can see down the very bottom of this slide, is currently at 37%, which is really one of the highest in the industrialized world. It's actually higher than the United States now, which is really saying something. But that figure is aggregated between the public and the private system. So if you were just look at public hospitals, it would be a little bit lower than that. I think it's about 33%. It's still 1 in 3 women will have a C-section. But if you were then just to look at the private system, those figures are much higher. They're certainly in excess of 50%. And there are some hospitals and some obstetricians in particular who have really exceptionally high C-section rates in excess of 70, 80%. So I think it's really important that we remember that cesarean birth and cesarean surgery is a life-saving operation. And certainly we are very, very fortunate in Australia to have, you know, widespread access to cesarean surgery. Although saying that, that's really only for people who do live in large metro areas. We know that there is an absolute dearth of of birthing options for women who live in regional and rural parts of the country, and also for Aboriginal families the options are even fewer, and so I think it's important not to sort of say, oh, everywhere has access to safe cesarean and immediate access to surgery and anesthesia, because that's simply not the case in Australia. There are some obstetricians who like to, I suppose, sing the praises of C-sections and saying how in the long run they're better and healthier for women, that they help women to avoid long-term pelvic floor damage. But in fact, there has been a lot of research, and including a very high-quality systematic review, which has shown very clearly that vaginal birth is safer for mothers and babies unless there's a really, really strong and compelling reason to have surgery. And if a woman has a uncomplicated vaginal birth, where she's able to birth freely, moving around, adopt upright, forward-leaning positions, that she's not pushing forcefully, what we call directed pushing, and that instruments are not used, so no forceps, no vacuum, and no episiotomy, then the risk of pelvic floor damage is actually extremely, extremely low. As I said, cesarean surgery is major abdominal surgery, and like with any surgery, there are risks involved both for the mother and for the baby. And those risks can be short, medium, and long term for mum. So really, again, it just goes back to, unless there is a clear, compelling health reason for having the surgery, then cesarean surgery really should be avoided if at all possible. And you can see in that slide here that there, what some of those risks are for mum and for baby. You may have clients who have had a previous cesarean birth and are very much hoping to have a vaginal birth with this baby. We call that a VBAC, or vaginal birth after cesarean. And the fear amongst healthcare providers is the risk that the previous uterine scar will separate and rupture during the labor. And that risk of uterine rupture is very, very low. It's less than 1%. There are many other obstetric complications which actually have much higher risk, even though they're still a comparatively very low risk of occurring. And yet it's because of this risk of the uterine rupture that ultimately really makes it very challenging for women to find a care provider who is truly VBAC supportive and who doesn't put in place a very large number of restrictive birthing requirements that actually act as barriers to VBAC success. So, we can certainly talk about VBAC, like in our live online check-in or at a future in-person get-together. But please let me know if you do have any questions about VBAC in particular. The next slide will look at when cesarean is necessary. And of course, as I said, it is a life-saving procedure and operation, and there are certainly many reasons when it is clearly medically indicated and is without doubt the safest way for a baby to be born. So we'll look at that just in a second. So, of course, there are a number of reasons why a cesarean would become necessary, and here is a list of a number of those reasons. So one, if mum is hemorrhaging, if the baby's oxygen supply is blocked, and the way that's understood obviously is through CTG, when we see that the baby's fetal heart rate is either extremely low or extremely high and is not recovering in between contractions. If a mum has a condition called placenta previa, that basically means that the placenta is covering either partially or entirely the cervix, and therefore is blocking the exit to the womb, and therefore there's no room for baby to be born safely, certainly without risking severe hemorrhage. If the baby's in a transverse position, so that's different to breech. A transverse lie is when the baby is essentially lying horizontally across the pelvis, and clearly, again, that makes it virtually impossible for baby to be born vaginally. If a woman has very poorly controlled diabetes or severe pregnancy-induced hypertension, severe preeclampsia, a range of comorbidities that can make her very, very unwell very quickly, and that we may also see have an impact on the baby. I mentioned in the previous slide about VBAC. So if a woman's had a previous cesarean and has a caregiver who is unwilling to support a VBAC, then her options may be quite limited, and she may feel that she doesn't really have any option other than a repeat C-section. And again, I think that is very much a case of the unwillingness and lack of support from the provider end, rather than the actual reflection of the safety, the evidence-based and proven safety of VBAC for most women. If a labour is simply not progressing at all, and that or that mum and baby are not doing well and not coping well with the labour. The baby's in a breech position, which we've mentioned already, and the care provider is not skilled at supporting vaginal breech birth. Again, you do not want a provider who does not have experience or confidence in supporting a vaginal breech birth. The baby, again, fetal heart concerns are a very, very large number of percentage of the reason why women end up with a C-section. If things like mum increases her fluid intake, has some oxygen, moves, changes position, if she has synthetic oxytocin, the syntocinon drip, if that's turned down or turned off, and that doesn't actually improve baby's heart rate. So they've tried all those things, and baby is still showing an abnormal fetal heart tones, then that's often certainly a reason to go to C-section. And then finally, if the client is carrying multiples, so twins or more, particularly if one of the babies is in a transverse position, because you may be able to get the one out vaginally, but the other one essentially is going to be stuck. Or again, if you have a care provider that just isn't skilled at supporting vaginal twins or multiple birth, because certainly that requires, again, a really skilled support team, medical team. So those are a number of reasons why somebody may actually legitimately require a C-section. So what's our role as doulas when supporting a client who needs a cesarean section? It's a really good question. I know there's a lot of information on this slide, but I tried to sort of squeeze lots of important things that relate to doula support with regard to C-section. Certainly, there's a big difference between an elective or a planned cesarean section. Say, for example, you have a client who has made that decision because baby's breech to go ahead with a planned C-section, or she has placenta previa, or whatever it may be. And so going forward with a C-section in those circumstances, generally a lot calmer. It's planned, it's known ahead of time, preparations can be made, lots of discussions can be had between the woman and her care provider. And so there's less likelihood of the sort of the stress and anxiety which can certainly occur with an unplanned or an emergency cesarean section. And I would say probably in the majority of cases with your clients, you'll probably be looking more at an emergency C-section. So labor has begun for, however it may have started, either spontaneous labor or an induction of labor. And for whatever reason, the decision has now been made to proceed with a C-section. In those moments in the birth space, there can be a lot of upset, a lot of disappointment, sometimes panic, sometimes anger, a lot of emotion, both from mum, from partner, if there are other family members as well in the room. And so really one of the first and most important things that you can do is to really hold that space amid amid the chaos, excuse me, and ensure that we can help to really restore calm and focus and reduce that fear in the room. So lots of soft words, lots of words of encouragement. Very importantly, making sure that your client feels that all her questions have been answered, if not, that that you can help facilitate for example, the obstetrician to come back into the room so that the mum and her partner can continue to ask any questions that they may have, or that they wish to convey their preferences and things that they would like to happen in the cesarean birth. Depending on, in addition to mum, if there is a partner or a close family member that she would like to have in the operating theatre with her, then that person will be able to go in and support. It's only in extremely rare circumstances when a true emergency C-section, which is then generally done under a GA or a general anaesthetic, and they are really quite rare. In those circumstances, a support person cannot enter the operating theatre, and that would include next of kin, like a partner or mum or whoever, and certainly doula. However, if, as I said, most emergency cesareans are still not true emergencies, there's still time for the questions, and sometimes women can be bumped for several hours because there is a more, pressing C-section which needs to be performed earlier. But generally they will allow one person into the room. With Birth for Humankind, it's not uncommon for the client to not have another support person. You are the support person, in which case you will be able to support and to accompany her into the operating theatre. You will still need to wear scrubs, and you'll be given instructions on, what to do, where to stand, all of those things. But really, your role will be no different as if she would have her partner in the room with her. Then you know, if, however, you don't go into the theatre because another family member or the partner is going to go in instead, then you would generally wait in a sort of family waiting area. If there are other relatives who are around, you know, who've been waiting and who may not know what has happened because they've not been in the birth suite, then, you know, you can play a really important role in actually going to the family and explaining what has happened and reassure them and let them know what is now likely to happen. Again, because they're very unlikely for anyone to sort of come and tell them that, or certainly not, you know, anytime soon. So that's a great role that you can play by sharing some information. Certainly, again, that the parents have allowed and will want that information passed on. They may not. And of course, that's very, very important. You know, if a client has her in-laws, you know, waiting in the room, in the family waiting room, but your client has said, I don't want anybody to know anything, please say nothing to anyone, then of course you must 100% you know, respect your client's wishes and say absolutely nothing until, you know, she's given, you know, you the okay to pass on information. If you are unable to attend the birth in the operating theatre, sometimes another option to explore is if you can get permission to meet your client in the recovery room after the surgery. And that's actually often something the hospitals are very amenable to, because what will typically happen is after the birth, once baby is being checked and everything is well with bub, hopefully, and this is an area that I think as a doula, again, we want to really have clients understand that skin to skin is so important. And the first thing that they should be advocating is immediate and uninterrupted skin to skin in theatre. And then the mum and baby and partner continues from the operating theatre through to recovery, through to postpartum. That's the ideal. That's the gold standard, where there's no separation of mum and baby whatsoever. However, the reality is, as we know, unfortunately, that's not always the case, and I would say in most situations is not the case. What will typically happen is that once the once the surgery is complete, which is about with a primary cesarean, the first C-section is 45 minutes to an hour maximum, then and the baby is well, the baby is wrapped up like a, you know, little burrito, put in the little bassinet, and a midwife will accompany baby and dad or partner and to the postnatal room, wherever mum will end up being, and they will wait with the baby until the mum is out of recovery, which could be an hour or two usually. So mum is not skin to skin with baby in those situations, and often the partner is so terrified and doesn't even want to pick baby up if they're lying there all wrapped up. So we can certainly encourage skin to skin with dad or partner if the baby can't be with mum skin to skin in recovery. But as a doula, you can potentially be in that recovery space, and that's very reassuring and comforting for mum. You can have your phone in there, which means you can relay information to the partner and mum back and forth and be a bit of a go-between. You can take photos and share them with each other. So it means that mum can see some of those really lovely first photos of baby in that first hour or so. So there are lots of things and lots of options that we can explore and that we can talk to our clients about. Once the transfer does occur and mum moves to postpartum and is reunited with her baby, then as a doula, you know, things that you could potentially offer is to go and get some hot drinks, you know, a nice coffee for dad, you know, some some maybe nicer food that might be available downstairs in the hospital as opposed to what comes on a tray, particularly if it's out of hours. If it's like the middle of the night, usually the best that the hospital can rustle up is some pretty dried up old sandwiches or a pot of jelly or something like that. So you might be able to get a hold of something a little bit more nutritious for them. And she may also ask for some help and support with getting baby onto the breast. Depending on your own comfort and confidence around that, if you don't feel that that's an area that you have a lot of experience or skill within, then it's absolutely fine to sort of say, look, let me go grab a midwife who can come and help you with that. Again, don't sort of feel a pressure to do something that's sort of outside your own comfort level and skill set as well. Some hospitals can actually also be very, very touchy and very funny about doulas helping with early breastfeeding and attachment. It really depends on the setting. I know hospitals where the midwife are like, oh, can you give mum a hand there? And others who'll be like, what are you doing? That's our job. So you might need to sort of gauge that one a little bit yourself. And of course, take your guidance from the client initially, first and foremost. Most doulas will stay an hour or two after the birth when the family are nice and settled and they've got everything they need. And, you're kind of going off a little bit of your own instinct as to kind of when it's time to make your exit. I usually will ask and say, is there anything else I can get you before I head off? Happy to run down or, grab a coffee or a snack. Do you want me to grab a midwife for you? Any of those sort of things. And if they sort of say, oh, we're all good, we're great, no, everything is fine, then you can kind of take your leave at that point. So yeah, hopefully you can see there's a lot that we do, even in a circumstance where cesarean becomes necessary. We still do play a very important role in helping to create an atmosphere of calm and warmth and focus, and reducing fear in the room, helping partners to feel supported or other family members to feel supported. And I would just finish by saying that I think it is the most important thing is that you want to ensure that you have these discussions with your client in the antenatal appointments. Don't wait until the birth has now kind of gone a little bit off the rails and everybody's talking C-section and you've never discussed that with your client before. Spend some time talking about cesarean, again, why it might occur, what does that surgery look like, and then how the birth may go down a slightly different pathway and how you can still help to ensure that birth is a really woman-centered and family-centered experience for everybody. So hopefully that sort of helps just to clarify that a little bit for you and remind you that in fact you continue to play a very important role. If anything, sometimes even more important role when people are feeling very vulnerable and potentially very frightened as well. So here's where we're going to talk about the golden hours. And as I mentioned at the beginning, the golden hours refers to the sort of first few hours following the birth. And it is a very beautiful and very special time for the new mum, her baby, and of course the family as a whole. What we really ideally want to happen is that mum and baby have uninterrupted skin-to-skin contact immediately from birth. And again, if your client does have a cesarean section, that she knows that she can advocate, and she should advocate strongly to have cesarean skin-to-skin following the C-section as well. There are so many reasons why skin-to-skin is important. And of course, you know, we immediately think of the bonding between mum and baby, which undoubtedly is one of the most important aspects of, you know, is in initializing and getting that bond between mum and baby established. However, it has some incredibly important other benefits as well. They include helping the baby to maintain an optimal body temperature, and the way that happens is that the mum's body, actually her core body temperature rises, and she becomes like a human incubator. So she can maintain baby's optimal body temperature far more effectively than a warmer. Mum and baby are in hormonal synchronicity, particularly following an unmedicated labour, and so that means that mum's body is overflowing with oxytocin, which we know is the love hormone, and then again really helps that bond to be cemented between mum and baby. And certainly baby's respiration is, you know, is better, and as we'll talk a little bit later in this module about the microbiome and the sort of a growing body of evidence that exists now, which show the enormous benefit of mum and baby, essentially the mum's body seeding the baby's microbiome, which starts excuse me, with the vaginal birth and the baby being exposed to all of that good bacteria in the birth canal, but then that they continue to be exposed to all that great bacteria on the surface of mum's skin, on and around the breast, you know, when mum kisses and hugs baby, and of course the colostrum and that first breast milk as well. So all those things are enormously beneficial for the baby. Some of the routine procedures, such as weighing and measuring baby, giving baby injections, the hepatitis B and the vitamin K, generally I think what you'll find is the hospitals also, you know, have no interest in doing those things, at least for the first hour. But really they can be delayed for as long as possible. There's no immediate need or urgency to do any of those things, and certainly nothing that can't wait at least a couple of hours at a bare minimum. The next slide, actually, what I'll get you to do is maybe just to pause after this slide, and then go to your videos and have a look at the video about skin to skin and the breast crawl, which is some really lovely little video from the NHS. Well, it's from the UK and features a birth in the National Health Service, which is not so hugely dissimilar to giving birth in the public system here in Australia. And I like this video because it actually shows a few babies being born, some via vaginal birth, some C-section, including a couple, you know, somebody who had a slightly more, you know, complicated birth, a home birth that required a hospital transfer. So it's a great way of seeing a variety of, you know, very realistic birth outcomes. But again, going back to the importance of that skin to skin and uninterrupted skin to skin with mum and baby. And you'll see also in the video something that's known as the breast crawl, which is an amazing sort of innate biological behavior that babies will do when they are familiarizing themselves with mum's breast, the scent of the breast and of the milk. Colostrum apparently has been shown to have a not dissimilar scent to amniotic fluid, so you know, hence why we don't want, you know, to wash any of that off on mum or to wash babies before they have that that initial attachment to the breast. It's really important that they smell all those things, and of course they are just absolutely covered in all of that wonderful good microbiome. So so we'll pause it here, go and watch that video, and then we'll carry on after that. So I hope you enjoyed watching that video. And here just is really just a summary and reminder of the various areas that we can support our clients, particularly with that, with that mother-baby connection. So the first being, perhaps helping to support the early breastfeeding attempts. And again, if you're not feeling confident or experienced enough, perhaps, and don't hesitate to just sort of say, well, I can, go grab a midwife and get some help for you to get things started. But certainly one of the great benefits of a baby having a really good long feed soon after birth is it really helps them to have a significantly good chunk of sleep as well, and it's almost as if they need to recover from the birth as well, and of course that allows the mum herself to have a really good rest post-birth. So that's one of the reasons midwives are so super keen to see baby have a good feed in that first hour or two after the birth. With your client's permission, or they may ask you if you wouldn't mind taking photos. Of course, this can be include taking photos during the labor itself, as well as immediately after the birth. It's a great thing to take off the hands of responsibility from the partner, because we want them to be in the photos as well. We want to capture them and their expressions. As you can see in this photo here, which is really one of my favorite photos of a former client of mine, and she had achieved her VBAC, which was just in itself the most amazing and emotional experience to witness. There's a beautiful little baby girl being born, and you can see her husband in the background there, who's really so taken with his own emotion as well. So I didn't clearly take that photo because I'm in it. A professional birth photographer who was there took it, but I certainly have snapped some really lovely photos over the year, usually by accident. But that's something you can certainly offer your clients as well. I always put a little caveat and say, I'm not a professional photographer, but I'm more than happy to take photos for you. My preference is always to take photos using the client's phone and not my own. If for whatever reason I do end up using my phone, I transfer the photos to them straight away, and then I delete them off my phone as well. If you have a situation, for example, with a cesarean section where there is some separation of mum and baby, again, what can we do to help really foster that connection? And so one thing to consider is to take like a muslin wrap or an item of the baby's, and put it on mum's chest and on around her breast for some period of time, and then go and pop that on the baby, and that way baby can smell mum. And that's another thing until we can bring mum and baby together. And of course, that we are always encouraging that skin to skin for as long as possible. As tempting as it is, to give the baby, maybe if her mum is there or mother-in-law and they want to have a cuddle, that there'll be plenty of time for cuddles, but really you don't get that immediate skin to skin back ever again. And so we really want to do everything we can to support that, and encourage that there is no separation of mum and baby. The next slide, actually, I'll get you all to just pause the presentation here again, and I'll get you to watch a really fun little video from NPR in the US, and it's all about the amazing human microbiome. It's a cartoon. It's animation, but it's very, very clever and quite funny, and also has some really interesting information about what happens when we you know, when we do things like, you know, have too many C-sections, what does that mean for the human microbiome, and for the future of you know, of the human race, essentially? So have a watch of that, and then I'll point you in the direction afterwards of a few other really great resources. If this is an area that you're interested in learning a bit more about, there's some really fabulous things to watch and study, if you so desire. So I'll share those with you after you get a watch of this one. I hope you enjoyed that animation about the human microbiome. Something you might have come across in your reading, or perhaps just hearing, maybe through friends, is this term vaginal seeding. What this basically means is it's a process whereby when a baby misses out on being exposed naturally to all of the good bacteria in mum's vaginal canal, there have been some studies conducted in the last few years looking at the potential benefits of providing baby with that bacteria via sort of a swabbing process. So for women that need a cesarean section, and obviously therefore the baby isn't going to be born vaginally, that prior to the cesarean, the mum can insert a cotton gauze cloth into her vagina to collect some of that good bacteria, and then after the baby is born, immediately following birth, the baby's mouth, face, inside of their lips, for example, can all be sort of swabbed with this, you know, with the good bacteria. So that's known as vaginal seeding or microbirthing in some cases, and is available in some birth settings, and it also depends on things like, you know, for example, you know, some hospitals make a requirement that the mum has had a Group B strep test and is GBS negative. Which, you know, to be honest, is kind of a ridiculous request, because one of the things that we do know about Group B strep is that it's a very transient bacteria. So if the mum had a vaginal swab for GBS at, say, 36 weeks, and she's giving birth, you know, at 41 weeks, for example, there's every good chance that she's not actually GBS positive at the time of birth. And the reverse is also true, that she may have tested negative, but then actually at the time of birthing is positive. So that GBS test requirement is really neither here nor there. And of course, you know, that plenty of babies are born to GBS positive mothers vaginally as well. So the next slide is actually going to look at what the evidence says about the benefits of vaginal seeding, given it is such a new area of research. And there's, in your sort of homework assignments, there's a variety of things to read and watch and listen to on this topic as well, because it is a really interesting area of growing area of research, a sort of study of epigenetics. And I think it's really, you know, useful for us as doulas, as birth workers, to kind of be on top of what the research is saying, and where this very interesting area of research is going in the future. So what does the evidence say about vaginal seeding and how beneficial it is? Look, the bottom line is that we're probably actually still quite a long way from actually having conclusive evidence to show whether or not vaginal seeding is safe and if it makes a positive difference to the baby, you know, in terms of, you know, long-term longitudinal studies and so forth. And so given that, it's sort of probably a bit premature to say that it's, you know, proven, that it's absolutely beneficial, or that it's absolutely, you know, risky, or, you know, an unsafe practice as well on the other side. As I said, there is ongoing research in this area. It is absolutely an area of growing interest and relevance, but truly, probably we're not quite at that stage yet where we can, certainly as doulas, sort of recommend or otherwise. What I think we found is that, you know, when this became popularized a few years ago, a lot of private obstetricians who, you know, were very, you know, had very high C-section rates, suddenly thought, oh, this is kind of a bit of a PR strategy to, you know, kind of make their services even more, you know, sort of enticing. You know, we offer vaginal seeding. So that and maternal assisted cesarean, which is another thing actually, which actually I might send some extra resources so you can read up on maternal assisted cesarean section. But I think my fear is that sometimes some of these things can be introduced as a way of sort of distracting from, you know, performing a large number of unnecessary cesarean sections. Saying all that, and that aside, there is no question that this is just we're really at the sort of the early starting blocks of some very, very compelling and very fascinating research. There, as you can see on the slide here, there was a film that was made, can't believe actually it was 9 years ago already, called Microbirth, by two British documentary filmmakers, husband-wife team. It's a fabulous film. It's well worth watching. You can stream it, you know, for just a few dollars. And if you just Google Microbirth the movie, it'll come straight up. But you'll see on the next slide here just some additional professional development and sort of continuing education opportunities that you can pursue if this is an area that, again, you're kind of really keen to learn a little bit more about. So I mentioned the filmmakers who produced that movie Microbirth a few years ago. They have actually gone on to create a series of really, really good, very high quality professional development online learning opportunities for birth workers in this whole area of understanding and learning more about the human microbiome. So what I would suggest is that you actually have a look and check out the free mini course about the infant microbiome. If you find it through the Microbirth film, you know, I've got the link up as well with your extra resources, so you can just go straight to that from there. They do have other courses which are paid courses. They're still very reasonably priced, but they go into a lot more depth on a variety of different topics. And for any of you who are sort of wanting to also pick up continuing education hours, perhaps not super important if you know your only training at the moment is the doula training with us. But if you went on, for example, to do, you know, childbirth educator training or something like that, then often as part of your ongoing certification, you do need sort of to show and demonstrate ongoing professional development and continuing education. And one of the great things about all of the microbiome courses is that they're all accredited, and they do allow you to pick up a number of important CPDs. But yeah, in the first instance, I would very much encourage you to check out their free mini course. It gives you a little bit of a taster and some really great information, and then watch the film as well, which is just fascinating. So there you go. So as I mentioned earlier, a doula would typically stay with the family for, you know, 2-3 hours maybe after the birth, again, depending on the circumstances. But on this slide here, you'll see a number of things that your client might experience and that are really helpful to kind of understand what's happening in those early hours post-birth. And again, depending on whether the birth was quite straightforward and it was just an uncomplicated vaginal birth, or was it a cesarean section, she will very likely have quite different experiences in these early hours. So following a vaginal birth, and again, particularly one where mum, was not exposed to synthetic hormones, to pain medications, for example, so essentially a physiological labour, we do see mum's sort of on this real birth high. It's a hormonal high, crazy peak levels of oxytocin flowing. Of course, even if mum, your client has had syntocinon, has had, pain meds or an epidural, she will still feel this to some degree, but we certainly see the most I suppose most visible birth high, when women have had an unmedicated labour. That high is often then followed by really profound exhaustion. And again, that goes back to that comment I made earlier about the real benefits of baby having a good feed in those first hours after the birth, so that baby can rest and mum can rest as well. Depending on, what number baby this is, some women may actually feel quite intensely the post-birth contractions. It's not super common with a first baby, but if she's had 2, 3, 4 or more children previously, many women actually, comment that the post-birth contractions are sometimes even more uncomfortable than labor contractions. So that's something just to be aware of if you are caring for a multip, a woman who's had a number of babies before. Some women experience really intense shaking and shivering after the birth. I've seen that with women who've had a very precipitous, a very fast labor. It's almost like an afterbirth shock, that their body hasn't quite caught up to what has just happened to them. So we want to keep mum really warm, lots of warmed blankets. And in the hospital, they actually have a cupboard. It's a massive heated cupboard where it keeps the blankets really toasty warm. So if you don't know where it is, you can always ask a midwife to bring some warm blankets, keep mum really snug, and so forth. And they will generally kind of settle after a period. The other time that she may experience that shivering and shaking is post-surgery. So the spinal epidural often is the cause of some of that shivering and shaking, the medications and so forth. So again, just reassuring her that's very, very normal. And if she's not got adequate sort of, blankets and stuff in recovery, that you could, ask the midwife if you could go grab some, or if they could get some for your client. Depending on the status of her perineum, so if she tore during the labor or needed an episiotomy and therefore had some suturing afterwards, it is normal for her to feel a degree of discomfort. If she had an episiotomy and suturing, then the obstetrician who's going to repair that tear will also ensure that your client has ongoing pain relief, and usually the first thing they do is actually a suppository of a combination of sort of a painkiller and an anti-inflammatory, and that will give her pretty significant pain relief for 4 to 6 hours, something along those lines, and then she can take an oral painkiller after that once it wears off. But letting her know that it's normal for it to be uncomfortable, that she should always ask for pain medication if it is very uncomfortable, and that she's not going to do any harm to herself, to her body, if she goes to the toilet, if she urinates, if she has a bowel motion. for example. And in fact, it's really important just to get all of that happening and moving normally again as well as soon as possible after the birth. As she establishes breastfeeding, again, particularly if it's a first baby and this is her first ever experience of a baby latching, it's normal for it to feel a little bit uncomfortable at first, but discomfort is not the same thing as pain. And we will talk in another module in detail about early breastfeeding, but it's really important that if the mum experiences pain, particularly nipple pain, that means that the baby is not latched well and properly, and it's really important that the baby come off the breast. And doing that, it's important not to pull baby off the breast, but to actually release that suction. And the easiest way to do that is for mum to put her baby finger basically between her nipple and the baby's mouth to release the suction, and then gently take baby off the breast and reposition. So discomfort, normal. Pain, not normal. Again, if you are feeling a little bit out of your comfort zone, that you're, not quite in your laneway as far as your knowledge and your confidence around early breastfeeding, then by all means, engage the support of one of the staff, one of the midwives in the postnatal unit. And then just finally, just a reminder of, how long we stay with clients. So, typically, it's important to wait until mum, and if her, she has a partner there or other family member, that everybody is sort of really well settled in. She's with her baby. Again, if, obviously if at all possible, obviously a very different scenario if the baby's in special care or the NICU. But if the mum and baby are together, we want them to be really settled. We hope that the breastfeeding is just sort of getting started. She's comfortable physically. She's had a shower. She's changed. She's had a snack. She's had a drink. All those things. Sort of, helping her to feel really comfortable and settled in. And after that, that's when typically as a doula, we would sort of make our quiet little exit. And then we would arrange to see the family again once they are settled back at home. So just to wrap up today's module, we're just going to look at what happens. So from when you leave, so that immediate postpartum, to when your client gets discharged from the hospital, if she's having hospital birth, obviously. So if all went really well and it was an uncomplicated vaginal birth, in most cases, your client will be discharged within about 24 hours. So you'll spend one night in the hospital before heading home. If your client has a cesarean, then typically she will spend 2 nights in the hospital, occasionally 3, but especially if that's because the baby's in special care or the neonatal intensive care unit, or the mum is unwell and really needs some extra time to recover. Women who do have complex circumstances, and they can be social circumstances, mental health, housing, complicated family, situations, then they can have an extended stay in hospital up to about 5 nights. But this is sort of a multidisciplinary care approach that would involve not just the maternity care team, but also the hospital's social worker, maybe a mental health worker, etc. as well. And often these things are kind of known about, obviously, well in advance, and there is an expectation, and these things are sort of organised and confirmed ahead of time. And I dare say again, working with Birth for Humankind, you probably will encounter that more frequently than, say, with private clients of your own. The exception would be if, as a private doula, you are caring and supporting a woman who is birthing in a private maternity hospital, in which case 5 nights is the standard. So, they will be in the hospital for a number of nights before they go home, even though physically there's no reason why they can't go home earlier. Generally speaking, again, because most of your clients, particularly as a Birth for Humankind doula, are likely to be birthing in the public system and going home pretty quickly, it's very unlikely that you would be visiting your client again in the hospital after you leave them that initial time. So in most cases, it would be, a case of just organising and liaising with your client to schedule a time for you to visit them, usually in their home, usually in the first week after they get home from the hospital. They will have, in most cases, a home visit by a midwife from the hospital within a day or so of them going home. They'll also will have a home visit from a maternal child health nurse. So as a doula, this is just my personal preference, but I tend to wait until after those appointments have taken place, just because it's a bit overwhelming for the new family to be kind of bombarded by a lot of visitors. So I let the hospital visit happen, I let the maternal child health nurse visit happen, and then once they're kind of, the dust has settled a little bit, then I'll sort of schedule my appointment with them. And with Birth for Humankind, you have a couple of postnatal visits. How many you choose to do with your private clients is entirely up to you. And we'll talk more about the postnatal visits in a future session as well. So that's pretty much how things look from birth to going home. So you'll find all those extra materials that I've mentioned as we've gone through the slides, the videos, and things you can read as well. And look forward to seeing you again next week.